friends, this is Dr. Ganga. Today let us learn a very important topic, which is membranous nephropathy. Now this topic will be dealt under the following headings. First we learn the definition, then what are the types of membranous nephropathy, what is the etiology and pathogenesis of this disease, how is the epidemiology, what are the clinical features, how do we investigate. In that, specifically, we learn in detail about the renal pathology that is seen in membranous nephropathy. How do we differentiate between primary and secondary membranous nephropathy? How do we work up secondary membranous nephropathy? Clinical course of the disease. What is the treatment regimen? What are the KDIGO guidelines that is used? That also KDIGO 2012 guidelines, and I have incorporated the latest 2020 public draft guideline of GN. And finally, we'll end this session with high yield questions, which will give you all the important points that you have to recollect and revise before the exam. Coming to the definition of membranous nephropathy. Definition of membranous nephropathy is nothing but deposition of immunoglobulin and complement. Which immunoglobulin? It is immunoglobulin G on the subepithelial surface of the glomerular basement membrane. Okay. So if you see this diagram, you will understand what this is. Now this is the glomerular filtration barrier, which has the endothelium. This is the glomerular capillary endothelium. Above that comes the glomerular basement membrane, above which comes the podocytes. Okay, so this is the endothelium, the podocytes become the epithelium, right? Now, the surface just beneath the endothelium is called as a subendothelial surface of the glomerular capillary wall, or GBM. The surface beneath the podocyte is called as the subepithelial surface. Now, coming back to the definition, if there is an antigen that is present in this area, an antibody will come and bind to it, that is immunoglobulin. Whenever there is antigen-antibody complex, what is going to happen? There is going to be complement formation or complement deposition. So, complement is going to come and deposit along with this antibody. So, IgG and complement beneath the podocyte on the subepithelial surface of the glomerular capillary wall is what is membranous nephropathy. So, I hope that point is clear. So, once this deposits, what is going to happen? It is not going to keep quiet, right? Because complement has variety of functions and activity. It is going to cause destruction of the tissue where it is getting deposited, because that is body's defense mechanism to remove the antigen that is not recognized as its own, right? So, podocyte injury will happen because here is the complex, right? So, this podocyte injury will happen, which will increase the permeability of protein through the glomerular basement membrane. Of course, here there are multiple filtration slits. There are slit diaphragms which interlace together to form the filtration slits. So, imagine this podocyte is damaged. These filtration slits are going to enlarge and protein is going to pass through these filtration slits. Okay, so final effect of all this happening is that proteinuria is going to increase. Okay. Now, what are the types of membranous nephropathy? It is basically classified into 3 types, but major it is only 2 types. If clinically for any purpose it is being asked, then it is only 2 types, that is primary or secondary. There is an additional category called alloimmune, which is not very common. Okay. Now, first let us deal with primary. What is primary? That is, there is antibody that is there to an antigen that is primarily present in the kidney. Okay. Now, these are the components, these antigens are the components which are normally present in the kidney, but in membranous nephropathy, they become immunogenic and antibodies are formed against them. Okay. So, which are these? The first antibody that is important is anti-PLA2R. Okay. That is phospholipase A2R receptor associated antibody. Now, these receptors and the antibodies that I am going to tell is very, very important. It has been asked as an MCQ multiple times. especially in institute exams. So it is very important to remember. And couple of years ago, there were only two important antibodies in primary MN. But today there are multiple additions to this. So along with telling these, I'll be telling you those extra antibodies that have been discovered recently. So once I tell that, I'll tell you how the questions are also going to be framed in that topic. So first is anti-PLA2R receptor antibody. Okay, the detail of this I'll tell later. The second one is thrombospondin. Okay, so that is anti-THS-D7A. So the most common is anti-PLA2R receptor antibody, which is seen in 70 to 80% of patients. So the most common antibody seen in primary MN becomes anti-PLA2R receptor antibody. Now, if anti-PLA2R receptor antibody is negative, then we should search for other antibodies. The first one is thrombospondin, which is seen in up to 5% of patients. Now, the additional antibodies which have been discovered recently is NEL1, that is neural epidermal growth factor like 1. Okay, so it is understood that this is the antigen that might be found in the podocyte to which antibodies are produced. The fourth type is semaphorin 3B. Now, remembering all these names might be difficult, but at least it's not important to know where these antigens are present in the podocyte, but it's important to know their name. Okay, so a mnemonic that you can use to remember these four in primary is ANTS. Okay, so where A stands for anti-PLA2R receptor antibody, N stands for NEL1, T stands for anti-thrombospondin 7A, and S stands for semaphorin. Okay, so these are the four things that represents primary MN. Now, there are other antigens to which antibody are detected, but it is seen in secondary MN. That is exhaustocin. Okay, there are two types, exhaustocin 1 and exhaustocin 2. This is mostly seen in secondary MN. So how the question can get framed is, they can ask all of these antibodies are seen in primary membranous nephropathy except. The options can be anti-PLA2R receptor antibody, anti-thrombospondin antibody, anti-NEL1, and it can be exhaustocin. So you know you have to pick exhaustocin because it is mostly seen in secondary. Okay. Apart from that, semaphorin 3B is another antigen to which antibody are formed in primary MN. So I hope this part is clear. These two, NEL1 and semaphorin 3B, won't be available in textbooks as of today. This is come only in the recent research articles. Okay. Now, that is about primary MN. Now, coming to secondary MN. Secondary MN happens because of multitude of diseases. In adults, one of the most common condition is malignancy. Okay. So, in malignancy, mostly solid tumors is what causes membranous nephropathy. So, solid tumors can be present in colon, stomach, lung, and prostate. So these are the most common locations, the solid tumors of which are going to form antibodies and cause membranous nephropathy. Okay, these are the common ones. The uncommon ones are non-Hodgkin's lymphoma, CLL, and melanoma. So it's okay if you can't remember the uncommon ones, but please remember the common ones. They should be solid tumors, mostly that is seen in colon, stomach, lung, and prostate. Okay, so these are the four things. Now next, coming to autoimmune diseases causing membranous nephropathy. The most common among them is class 5 lupus nephritis. We know that lupus is divided into 6 classes, the 5th class of which is called lupus membranous nephropathy. So lupus presenting as membranous nephropathy, that is a secondary membranous nephropathy, happens because of autoimmune diseases. Now, not just lupus, there are other autoimmune diseases also which can cause membranous nephropathy, that is rheumatoid arthritis, autoimmune thyroid disease, IgG4 related systemic disease, anti-GBM and ANCA associated crescentic GN. Okay. So, apart from lupus, RA, thyroid diseases, IgG4 and ANCA, anti-GBM, all these are the conditions which can secondarily cause membranous nephropathy. Next, coming to infections. Okay. Among infections, the common infection is hepatitis B. Okay. Now, this is a common infection that can cause membranous nephropathy. Among the uncommon, it is hepatitis C, HIV, syphilis, schistosoma. So, these are some uncommon infections that can present as membranous. So, common, remember, it is hepatitis B. Okay. Hepatitis C mostly presents as MPGN, but hepatitis B mostly presents as membranous nephropathy. So, three major sections are over, that is malignancy, autoimmune diseases and infection. Now, next is drugs. Drugs like NSAIDs or COX-2 inhibitors can cause membranous nephropathy. Apart from this, mercury containing drugs, gold salts, penicillamine and butylamine. Okay, any drugs that contain mercury. Okay, now miscellaneous sarcoidosis, anti-cationic bovine serum albumin. I'll come to this in the next slide. Okay, so these are the secondary causes. Now, next is alloimmune. Okay, that is graft versus host disease after transplantation, that is hematopoietic stem cell, de novo membranous nephropathy in a renal allograft, and feto-maternal alloimmunization due to neural endopeptidase. Okay, so this feto-maternal alloimmunization, I'll come to that in the next few slides. Apart from that, any hematopoietic stem cell transplantation when there is graft versus host disease, or in the graft kidney that is placed in the person with ESRD, if there is membranous nephropathy, then we call it as de novo membranous nephropathy. So, these two are the important alloimmune causes. Okay. So, this is about the types of membranous nephropathy and what is the etiology of these types. Now, coming into etiology and pathogenesis. Whenever it is membranous nephropathy model, it is divided into two. One is experimental, which was done very early, and second one is what is seen in the humans. Okay. Now, experimental model, the first one is Hayman nephritis. See, it is important to remember two things from this slide. The first point in that is the experimental model of Hayman nephritis. Okay. It is caused by a fixed antigen called megalin. So, this has been asked as an MCQ, which is the antigen in Hayman nephritis. It is megalin. Fixed antigen means it is already present in the podocyte, right? Now, what is the pathogenesis is, this megalin is a transmembrane receptor of the LDL family which is present on the basal surface of the podocyte, right? Now, what happens is there are circulating anti-megalin antibodies. So, this is the basal surface of the podocyte. Here is the megalin which belongs to the LDL receptor family. Now, there are circulating anti-megalin antibodies which will come and bind here. Once they bind to the antigen antibody complex, it is going to cause shedding and it will fall on the GBM. Okay, it will fall on the GBM. Once here, this antigen antibody complex, we know it invites complement, okay, as an additional guest to destroy this antigen. Now, once that happens, complement mediated injury will happen that will disrupt this glomerular basement membrane, actin, and it will cause proteinuria. Okay, so this is the mechanism by which proteinuria occurs in Hayman nephritis. You know, this is a rat model. This is not a human model. It is because of megalin antigen. Okay, that is the first thing. Second one is cationic bovine serum albumin animal model. Now, what happens is this cationic bovine serum albumin is positive charged. This goes and binds to the negatively charged GBM. So, this is something called planted antigen. That means already the antigen is not present in the kidney. Here, megalin was already present in the podocyte. Here this bovine serum albumin, which is cationic, is not found in the podocyte. Okay, so it is present in the circulation. It goes and deposits to the negatively charged GBM. Okay, then this causes local complement activation, and then further it is the same pathway. Once complement activation occurs, glomerular basement membrane is injured and patient has proteinuria. Okay. Next, coming to human membranous nephropathy. Human membranous nephropathy also multiple antigens have been implicated. So first is neutral endopeptidase or NEP. If you remember, I had told this as an example of alloimmune type of membranous nephropathy. So this neutral endopeptidase is a podocyte protein. Okay. What happens is, if a mother is deficient of this neutral endopeptidase, what is she going to have? She is going to have antibodies to this neutral endopeptidase. Now, what is going to happen? The fetus is going to form, but the fetus is going to have this, fetus is going to have neutral endopeptidase, right? So, what will happen? These maternal antibodies from her blood enters into the fetal blood and goes and binds to this neutral endopeptidase in the kidney of the fetus, okay, and it causes membranous nephropathy. So this is what causes antenatal membranous nephropathy. So the example for antenatal membranous nephropathy is anteneutral endopeptidase that is formed against the NEP, okay. So this is antenatal MN. Second one is membranous nephropathy in chronic GVHD and allogenic hematopoietic stem cell transplant. Third is the most important type, that is antibody against M-type phospholipase A2 receptor, that is anti-PLA2R. Okay. Now this has gained tremendous importance in the diagnosis, management and prognosis of patients with membranous nephropathy. Okay. PLA2R belongs to the mannose receptor family. Okay. Its main function in the podocyte is not very clear, but we know that this is present in the podocyte, and antibody against this is what is seen in 75 to 80% of patients of primary membranous nephropathy. Okay. Apart from this, there is antibody against thrombospondin type 1 domain containing 7A. This is seen in 5 to 10% of patients who are negative for anti-PLA2R receptor antibody. So when a patient of membranous nephropathy comes to us, first thing is if we are suspecting primary membranous, we are going to send anti-PLA2R receptor antibody. If that comes negative and still your suspicion is strong, then it is possible to send anti-thrombospondin, which, because it's rare, you don't want to over investigate the patient at the first visit itself. So if anti-PLA2R is negative, then you can go ahead and do anti-thrombospondin. Okay. Now other antibodies are also seen, which is against aldose reductase, enolase and superoxide dismutase. The newer antibodies like semaphorin 3B and NEL1 is also seen in primary membranous nephropathy. Now, this picture shows the pathogenesis, whatever I have explained. That is, there are two types of antigen. One is intrinsic podocyte antigen, which is already present on the podocyte membrane, or it can be planted. That is, the antigen is present in the bloodstream. It goes and gets deposited in the glomerular basement membrane. So, the example for this is cationic bovine serum albumin. Since it is positively charged, it is going to go attached to the negatively charged glomerular basement membrane. Here you can see, for example, think this is anti-PLA2R receptor antibody, which is present in the subepithelial surface of the podocyte. Antibodies that are present in the circulation are going to go attached to this antibodies, and that is what is going to cause the antigen antibody complex, complement injury, GBM injury and proteinuria. Similarly, planted antigen, here you can see the antibody that is there in the circulation, antigen that is there in the circulation, and also antibody is there in the circulation. So these are going to go, and once bound to the GBM, the antibodies are going to go attack them and cause this problem. Now coming to the epidemiology of this disease. this disease is mostly seen in adults. It has a peak incidence of 4th to 5th decade, that is seen in primary membranous nephropathy. In children, membranous nephropathy is rare, but it can occur secondary to hepatitis B. Okay, if you remember, in the infectious causes of membranous nephropathy, in secondary, I told hepatitis B is the most common. So in children, hepatitis B virus infection can lead to membranous nephropathy. Okay, and also it is seen more common in males than in females. Now coming to the clinical and serological manifestations. Clinical manifestation, of course, it comes under the disease causing nephrotic syndrome. So nephrotic syndrome is seen in 60 to 70% of patients. There is only normal or mildly elevated blood pressure. So blood pressure is mostly normal. Only in 10 to 20% of patients there is elevation. There will be complications of nephrotic syndrome, like there will be hypercoagulability, there will be hypoalbuminemia, there will be edema, there can be thrombosis because of hypercoagulability, increased incidence of infections. So all these adverse effects due to nephrotic syndrome can be seen. Okay. Then there can also be features of secondary disease, that is, if there is malignancy of the colon, or if there is malignancy of the stomach, malignancy of the lung, prostate, patient will present accordingly. Or it can be an autoimmune disease or infection. So patient is going to have features of that particular disease which is going to cause secondary membranous nephropathy. Okay. And what happens is, think there is this antigen antibody complex that is present in the GBM. Okay. Eventually this antibody levels are going to come down, either because of our treatment or because it's a secondary cause and the cause has been treated. But once extensive podocyte loss occurs and GBM damage occurs, despite immunological remission, proteinuria continues, because proteinuria doesn't happen because of the antigen antibody complex directly. It is because of complement mediated injury to the GBM and podocyte, okay, which will cause the damage. So even after it is removed, whatever damage that has caused is going to persist. So it is not going to recover despite removing the antibodies. Okay, so this is why treating this condition early is very important. Now investigation. First, when urine routine is done, benign urinary sediment is seen. Patient is going to have non-selective proteinuria. Okay, that is, patient is going to have both albumin and globulin tubular proteins that is secreted into the urine, unlike in minimal change disease where you see selective proteinuria. Okay. Next is microscopic hematuria is seen in 30 to 40%. No frank hematuria, but in your urine routine report, few RBCs can be seen. But RBC cast is rare. Generally, active proliferation or RBC cast is not seen. Okay. Serum complement levels are going to be normal. Despite the fact that this is a complement mediated injury, it is caused by complement that is locally deposited in the kidney. So serum levels are going to be normal. Okay. Increase in creatinine or AKI is also rare, that is seen in less than 10%. So basically it is going to present as nephrotic syndrome, which is most common. Hypertension AKI is seen in less than 10% of patients. Urinary analysis is going to be bland. There can be few RBCs. Proteinuria is non-selective. Okay. Now coming to the light microscopy in renal pathology. This is divided into 3 stages. Okay. The first stage is glomeruli and the interstitium looks absolutely normal because any antigen antibody deposition cannot be picked up. In this stage, only electron microscopy is useful because this antigen antibody that is deposited can be picked up by electron microscopy alone. Okay. Stage 2 is there is homogeneous thickening of the capillary wall. Okay. So let us come back to this picture. This is the podocyte. This is the GBM and this is the endothelium. Okay. So the first stage, just imagine that there are antigen antibody complex that is there on the GBM. Okay. Now second stage, what happens? The complement mediated damage is started, So because of the inflammation, there is homogeneous thickening. So thickening of the glomerular basement membrane is seen. Okay. Then what happens? There is going to be spike-like configuration or projections in the GBM that is seen in methionine silver. What is going to happen? When the GBM is thickened, think this is the antigen-antibody complex. It would be easier if you start thinking in 3D plane. Think of this as the antigen-antibody complex. So there is going to be inflammation surrounding this area and excessive GBM deposition surrounding this area. Okay. So imagine how this is going to appear, right? Antigen-antibody complex is sitting like this. Around it is the inflammation. So it is going to show as a spike, right? So this is, imagine this is going to show like this. That means here there is antigen-antibody complex. Again, it's going to show like this, okay? So the spike-like configuration or projections in the GBM can be seen in methionine silver staining of the light microscopy, okay? Now this is the second phase where there is inflammatory reaction around the antigen-antibody complex. Now what happens? Eventually this antigen-antibody complex are destroyed and it is removed. So that will leave a crater that will appear as a lucency, because imagine this antigen-antibody complex is removed. Imagine this is getting removed. So there is a crater that forms and there is lucency in the glomerular basement membrane. So these three are seen in, these are the three stages that are seen in case of membranous nephropathy, with spike-like configuration is seen in stage 2 of membranous nephropathy. Now, along with that, leukocyte infiltration is absent. Changes in podocyte and basement membrane are seen. There is no hypercellularity. Okay, no hypercellularity, no leukocyte infiltration. Now, coming to the immunohistochemistry. Immunohistochemistry is a technique to identify the deposition of antibodies in membranous nephropathy. Finely granular capillary wall immunoglobulin. Actually, it's important to remember this because there can be clinical questions like a patient presents, a 40-year-old male presents with nephrotic syndrome. Okay, light microscopy is showing spike-like configuration and immunohistochemistry is showing fine granular deposition of IgG. What would be the diagnosis? So here it will be easy. If you know this, it will be easy to clinch the diagnosis that it is because of membranous nephropathy. Okay, so there is fine granular, if they would like to show by this picture, capillary wall IgG that is seen in the subepithelial space in the immunohistochemistry. Okay, here or like this, however it is seen. Okay, predominant in this is IgG4. Okay, most predominant among the IgG is IgG4. Other immunoglobulin, if it is found like IgA, IgM, then it is important to think about secondary causes. Okay, then C3 break, we know that complement also comes and deposits here. So C3 breakdown products like C3b, C3c, it's possible to find them. Okay. Now, apart from this, generally other complements are not found, but if C1q is present, then it is important to think of lupus as the cause of membranous nephropathy. Okay. Now, apart from this, that is antibody and complement, we can pick up another thing, that is PLA2R antibody receptor staining in the this PLA2R receptor, there is a antibody, there is a possibility that it is present only in the kidney, that is only in the glomerular stain, but in the blood, that is serology, it is negative. Now, how can it be present only in the kidney and be absent in the blood? There are two conditions. First is very early membranous nephropathy, that is this antigen is present, this anti-PLA2R whatever is formed is directly going and getting deposited in the kidney, and only when it is overwhelmed and all the sites in the kidney are full, then only it gets spilled into the blood. Okay, so if it is very early membranous nephropathy, we can't see. Second is late, that is imagine the antigen antibody complex is formed, then it is shed off, and that antigen antibody sequence is destroyed, and probably patient has received treatment, is going into remission. So there is no new production. So in these two conditions, it is possible to see only PLA2R receptor antigen antibody staining in the kidney, but in the serum, if you search for anti-PLA2R receptor antibody, it is going to come negative. Okay. So we finished light microscopy and immunohistochemistry. Let us go into electron microscopy. Okay. Electron microscopy, there is subepithelial electron dense deposits, right? So here there is no confusion now. This is GBM. This is the subendothelial surface. This is the subepithelial surface. Okay. So in the subepithelial surface, there is electron dense deposit. Now this is also classified into multiple stages. Stage 1, there is little change in the glomerular basement membrane. If at all, there can be effacement of the podocyte foot process. Okay. Now, stage 2 is when there is basement membrane laid down between deposits and spikes. Okay. Like I said, basement membrane is going to get deposited, making the GBM thick. So, when that is deposited, it becomes stage 2. Stage 3 is deposition of new basement membrane material around the spikes. And stage 4 is thickened basement membrane, loosened deposit, spikes are less apparent. That is, by it is stage 4, the antigen antibody complex is removed out. So those areas appear loosened and there is not going to be any spike, because spike is nothing but the antigen antibody, right? So that is also going to be removed off. So it is mostly thickened basement membrane and loosened area that can be seen. Okay. Tubulo-reticular inclusions can be seen in lupus nephritis associated membranous nephropathy. Now, this is about the light microscopy, electron microscopy and immunohistochemistry. Now, let us see if we can differentiate between primary and secondary membranous nephropathy by doing kidney biopsy. Why is it important to differentiate primary from secondary? This is important because the treatment for both differs. See, primary, the most common treatment is immunosuppression. Okay. But in secondary, the most important thing is going to be to treat the cause. Okay. So this is why it is important to differentiate between the primary and secondary membranous nephropathy. Now, in the primary, in the immunofluorescence, we see mostly IgG4. This is maximally seen. Apart from this, you can see IgG1 and IgG3. But in secondary, it is mostly IgG1. IgG4 may be seen in the last. Okay. IgA and M are absent generally in primary. In secondary, generally they are present. Mesangial immunoglobulin staining is absent in primary, but it can be present in the secondary. That is, mesangial deposition of antibodies can be seen. Okay. C1q will be negative or weak in primary, but it can be positive in secondary, especially because of lupus. Okay. PLA2R are positive and it co-localizes with IgG. Here in secondary, PLA2R is negative. So basically, it is in primary we see IgG4 and no mesangial deposits generally, and along with that PLA2R, which is co-localizing with this IgG4, can be seen, and others like C1q are negative. Okay. When coming to electron microscopy, there will be only subepithelial deposits, rarely mesangial deposits in primary. But in secondary, along with subepithelial deposit, mesangial deposits may also be seen. Okay. Now, how do we work up a patient who comes to us with membranous nephropathy? So, in all patients, blood pressure examination, renal function test, which involves serum creatinine and creatinine clearance, urine analysis, that is including urine routine and microscopy, urine protein excretion has to be checked, serum albumin, serum cholesterol, renal biopsy and anti-PLA2R receptor antibody. Okay. So these are the general tests every patient undergoes. Now, if we are suspecting secondary disease, then we have to send HBsAg, HCV, ANA, anti-dsDNA, which is seen in lupus nephritis, and complement levels. So all this is when we suspect secondary disease. In selected patients who have suspected thromboembolic events, flank pain, hematuria or acute renal failure, then we should suspect that renal venous thrombosis has happened, because that is what can cause all these symptoms, and we have to do Doppler ultrasound, contrast CT and MRI. Okay. Now, if there is sudden decrease in the renal function of these patients and they develop active urinary sediment, three important causes we have to think about. First is anti-GBM, second is ANCA, and third is interstitial nephritis. Okay. Now, it is seen that in anti-GBM and ANCA, whenever there is destruction of GBM or the podocyte, there is exposure to new antigen or neoantigen, which can lead to later development of membranous nephropathy. So, if the patient is having any of these conditions, patient might present to us as membranous nephropathy, but underlying disease might be anti-GBM and ANCA. So, if there is sudden rapid deterioration of kidney function in a membranous nephropathy patient, which generally will not happen, think about these two conditions. Okay. Then if suggestive symptoms are there or age is above 50 years in our patient, then malignancy screening has to be done. Like for lung carcinoma, X-ray can be done, and for colon, colonoscopy can be done, prostate examinations can be done. All this should be done for symptom specific, and if the patient is more than 50 years, we have to do screening for malignancy. So this is how in specific secondary conditions we are going to evaluate the patient. Now, coming to secondary membranous nephropathy, it is seen in 20 to 30% of patients. In adults, malignancy is an important cause. So mostly we learned it is going to be solid tumors, which is seen in colon, kidney and lung. Okay. Now, hepatitis B associated or infection associated, it can affect adults and children who act as carriers. This is seen most in endemic areas, and liver disease may or may not be seen. Even in children, this is generally going to go through a benign course, that is, they might enter spontaneous resolution. Okay, so liver disease is not seen, kidney disease is also not much severe. So this is the thing about hepatitis B associated membranous nephropathy. Okay, so it is generally seen in areas where hepatitis B is endemic. Next is drugs. Any drugs like NSAID is causing, we have to discontinue the drug, and mostly kidney will recover. Okay, NSAIDs mostly recover after 1 week, but gold and penicillamine induced take longer time for recovery. Now coming to the clinical course of this disease. Okay, spontaneous remission is seen in 30% of the patients. Okay, that is, even without doing anything, patient is going to attain remission. Now, which are these patients whom we can think will go into spontaneous remission? That is, if there is low level of proteinuria, that is proteinuria which is less than 4 gram, then we can suspect that these might go into spontaneous remission. Similarly, female gender is also a group of people who are more likely to enter spontaneous remission. Okay. If the patient has subnephrotic proteinuria, there is a 50% chance they are going to recover, but 50% chance that they might progress into nephrotic state also. So they should be periodically monitored to see if they are entering nephrotic state. Now, there are some clinical and investigation parameters that helps us in predicting poor outcome. Okay, clinical features. So age, older is worse than younger. Gender, males are more affected than females. HLA type, HLA B18, DR3, BFFL, if it is present, then it is going to be worse. Hypertension, if it is present, it is going to be worse. So these are the clinical parameters that are going to predict. Okay. Apart from this, if the serum levels, albumin is less than 1.5 or if creatinine is elevated, then that also can predict. Next is urine protein. Okay, if nephrotic syndrome is present, it is a poor predictor. Along with that, if proteinuria is more than 8 gram for more than 6 months, and there is IgG excretion, beta-2 microglobulin excretion and C5b2 C9 excretion, which shows that the glomerular filtration barrier is damaged and the tubulointerstitial compartment is also damaged. So, this is excreted from the tubulointerstitial compartment, right? So, if this is also damaged, then it can be suggestive of a poor outcome. Okay. Then biopsy changes, that is if there is interstitial fibrosis, tubular atrophy and glomerulosclerosis. All these are evidences of chronic damage to the kidney. So, if all these are present also, it is poor prognosis. So, we dealt with clinical, serological, then urine examination, that is urine protein, and what are the biopsy changes that can cause all these problems. Okay. Now, coming to the risk categories, based on the clinical presentation and investigation, these patients can be divided into 3 risk categories. Okay, they are low risk, medium risk and high risk. Low risk are patients who have normal serum creatinine and creatinine clearance, but that is basically this risk is divided based on 2 important features. First is eGFR, second one is proteinuria. Okay, so if they are low risk, that means they have normal serum creatinine and that is normal eGFR and proteinuria is less than 4 gram per day over 6 months. If they are medium risk, that means they have normal or near normal eGFR or creatinine clearance. Proteinuria is 4 to 8 gram per day. Okay, this is present over 6 months. Then high risk is when the renal functions are deteriorating or it is lesser, eGFR is lesser and proteinuria is persistent with more than 8 gram per day for 3 months. Okay, so above 2 are for 6 months, this is for 3 months. So, if this is how we classify patients based on GFR and based on proteinuria into low, medium and high risk. So, this helps in 2 things. One is it helps us to decide how fast to start therapy, because in high risk patients it is better to start off immunosuppression soon rather than waiting with conservative therapy. Okay, and second thing is it is going to show whether there is going to be progression to ESRD. Okay, so this is the advantage of dividing into risk categories. Now, the significance of anti-PLA2R. Significance of anti-PLA2R receptor antibody. Okay. Now, this can be used for diagnosis. That is, if the serum is showing anti-PLA2R receptor, then that means the diagnosis of primary membranous nephropathy is confirmed. Next is it can predict spontaneous remission. Okay. That is, if the anti-PLA2R levels are low at diagnosis, that means it has a chance of going into spontaneous remission and he might not require aggressive immunosuppression. Third is disease activity. Similarly, if the levels are high, that means there is more disease activity. So, it is directly proportional. Response to treatment. Again, if the levels are low, patient might respond. If the levels are high, it might be harder. Risk of progression, again based on the level. If the levels are high, then the chance of progression is highly likely. Stopping treatment. Before stopping, we have to document that the patient has achieved immunological remission. That is, the anti-PLA2R receptor antibody level is negative. So, anti-PLA2R receptor antibody is used in diagnosis, in prognostication and also deciding the treatment and when to stop the treatment. So, these are the major uses for which anti-PLA2R receptor antibody is used. Okay. Now, when does relapse occur? Relapse we know around 30% of patients achieve spontaneous remission. 25 to 40% of patients achieve complete remission, whereas 50% achieve partial remission. Among the patients who achieve remission, only 25 to 40% is complete, but rest of it are all partial. Okay. Now, majority having subnephrotic proteinuria will have stable long-term kidney function. That is, if they have attained partial remission and having subnephrotic proteinuria, even then their renal function is going to be good for quite long time. Now, coming to the treatment. Okay. Now, in the treatment, first we have to give non-immunosuppressive therapy. Then we have to give immunosuppressive therapy. Non-immunosuppressive therapy will include control of blood pressure, control of proteinuria. Okay. So, first thing is control of edema by giving diuretics. Then for hypertension, RAS inhibitors. For hyperlipidemia, statins. Okay. Now, in proteinuria, RAS inhibitors, there is 30% proteinuria reduction and effect occurs within 3 months of therapy. Okay, once we give RAS inhibitors, the proteinuria reduces by 30% and within 3 months of therapy, generally the effect is seen. So, if proteinuria is not reducing by 3 months time and it is not reducing by at least 30%, that is an indication to show us that this therapy is not working and he or she requires more aggressive therapy. Okay. Then coagulopathy, if generally the proteinuria is more than 10 gram and if the albumin is less than 2.5, that means patients are more prone for coagulation, hypercoagulability, and they should be given therapy for that. That is, they should be given anticoagulants to prevent the formation of clot. Okay. Now, coming to immunosuppressive therapy. First, we dealt with the non-immunosuppressive therapy. Now, we are going to deal with the immunosuppressive therapy. Okay. Now, coming to the immunosuppressive therapy, it is seen generally when there is persistent nephrotic range proteinuria, it is to be used. That is, it is more than 4 gram. That becomes the medium risk to high risk. Or proteinuria has not declined more than 50% from baseline over a minimum observation period of 6 months, despite maximum antihypertensive and antiproteinuric therapy. That is, think the patient has a proteinuria of 4 gram. Okay, you give the patient ACE inhibitors, ARB, you give diuretics, and still then this thing is not declining. Proteinuria is not declining. Then you have to consider immunosuppressive therapy. Or there are severe disabling or life-threatening symptoms related to nephrotic syndrome, like there is hypercoagulability, okay, which can lead to increased clot formation and it can cause cortical venous thrombosis, coronary artery disease. So, because in this condition you cannot allow the blood to be hypercoagulable, okay, hence you start treating. Then if there is disabling symptoms, like there is anasarca, patient is unable to move, severe proteinuria, then we have to think. Rise in serum creatinine greater than 30% within 12 months. This shows that the kidney is going into CKD. So, if last time the creatinine was 1, today the patient after 1 year the creatinine is 1.3, 1.5, then it is an indication to treat. Okay, and high levels of anti-PLA2R receptor antibody, like I mentioned in the previous slides, if anti-PLA2R receptor antibody level is high, it might indicate that the patient cannot go into spontaneous remission. So, we will have to support the patient by giving immunosuppressive therapy. Now, we decided in which conditions we have to give immunosuppressive therapy. Now, what are the immunosuppressive therapies? There is a very important named immunosuppressive therapy, that is Ponticelli or modified Ponticelli. Okay. So, what is this regimen? This is alternative of steroid along with alkylating agent. Okay. Now, steroid generally what is given is methylprednisolone. It is given initial 3 days, 1 gram is given as pulse followed by oral steroid, which is 0.5 mg per kg per day, which is given for 27 days. Okay. So, this is given in months 1, 3, 5. Okay. So, this is the one. Alkylating agents can be 2. One is chlorambucil, where it is called as, if this is used, it is called as Ponticelli regimen. The second one is cyclophosphamide. This is used in modified Ponticelli regimen. Okay. Now, this alkylating agents is mostly oral and it is given in months 2, 4 and 6. So, this is what is about Ponticelli regimen and modified Ponticelli regimen. Okay. Now, what is the advantage of giving this regimen? Okay. Complete or partial remission rate is up to 80% in this regimen and the progression to CKD is reduced by this regimen. So, renal survival is improved. Okay. Relapse rate is approximately 30% within 2 years. So, 80% of patients who receive this treatment are going to achieve remission and relapse rate is going to be only 30%. That is, a small fraction of them is going to get remission by relapse by 2 years. Okay. So, this is beneficial especially when renal function is normal initially With deranged renal function, what happens? Cyclophosphamide can lead to severe adverse effects. Okay. Now, when the cyclophosphamide is exposed to the patient or given to the patient multiple times, there can be higher incidence of malignancy. Generally, when given, is given at the dosage of 2 to 2.5 mg per kg per day. Okay. So, if 100 mg is given per day for 6 months, that is, it means 2 times if the patient receives modified Ponticelli regimen, it will amount to approximately 10 to 12 grams of cyclophosphamide, the cumulative dose that the patient has received. So, beyond this, we cannot give cyclophosphamide. So, the number of times a patient can receive cyclophosphamide or modified Ponticelli regimen is maximum 2 times. That is, even if remission occurs one time, once more, if the patient has responded initially to modified Ponticelli, we can give that. Okay, but such usage maximal 2 times can be done, not beyond that. Now, we read about alternating corticosteroid with alkylating agents. Now, plain corticosteroids, it was found that there is no use of using it as monotherapy. Okay. Coming to cyclosporin plus steroid, that is, it is CNI. CNI we know calcineurin inhibitors are 2, that is cyclosporin, and second one is tacrolimus. CNI itself has an effect to reduce proteinuria, that is by stabilizing the actin. Okay. So, this is how it is going to reduce the proteinuria. It is going to stabilize the actin and the podocyte, and it is going to reduce the proteinuria. So, remission rate of 75%, which is comparable to modified Ponticelli, which gives 80%, and it can increase to 85% by 12 months. But the main problem with this is relapse rate is higher, where there it was only in 2 years it was 30% here, but the moment you discontinue, within 6 months, around 40% of patients are going to relapse. So, relapse rate is very high with CNI therapy. Okay. Now, at least 25% reduction in proteinuria takes place by 3 to 4 months. That is, once we start the therapy, by 3 to 4 months itself, you notice good improvement. That is, 25% reduction in proteinuria is going to occur. Then it means CNI is working. But within 4 months, you find that there is no change in proteinuria and patient is continuing to be the same. That should give us an indicator that CNI therapy is not going to work and we have to switch to alternative therapy. Okay. So, that is one group. Second group is tacrolimus with steroid. This has not done as good as cyclosporin. The remission rate is around 76% and relapse rate is around 50%. Okay. Now, there can also be adverse effect like CNI, cyclosporin itself can cause hypertension, nephrotoxicity. Tacrolimus can cause diabetes mellitus. So, all these are the adverse effects you are going to see by starting this therapy. Okay. So, what we understand from this is it is beneficial in long term. That is, if you want to continue the therapy for 1 year, 2 years, it is beneficial. But if you give a short term treatment like in modified Ponticelli, assume you are giving only for 6 months, the moment you stop within next 6 months, 40% of your patients are going to relapse. Okay, so unless you don't want to give a long term therapy, don't choose this as the treatment regimen for patients. Now, 3 classes of drugs we have finished. Next is MMF. MMF might not work as monotherapy. The fourth and the most important drug which has gained maximum importance in membranous nephropathy these days is rituximab. Okay, by using rituximab, the remission rate is around 60 to 70%. It can be used in a patient who has failed immunosuppressive therapy previously. So, remember I told you a situation where relapse occurs. So, first time you treat the patient with modified Ponticelli. Second time you treat the patient with modified Ponticelli. You are exhausted with modified Ponticelli. You cannot use anymore. So, if third time the patient relapses, you cannot use cyclophosphamide containing regimen. So, you have to give rituximab. So, in a patient who has failed immunosuppressive therapy and has relapsed or who has not achieved remission at all, rituximab can be used. And the action of this drug can be monitored by decline in anti-PLA2R receptor antibody, because we know that rituximab acts against anti-CD20. It is going to reduce the production of B cells and plasma cells, which is going to produce the antibody. So the level of anti-PLA2R is going to decline, and that is what is going to be indicator for us to see that rituximab is functional. Okay, so it causes immunological remission, and it has lesser adverse effect when compared to high-dose steroid, cyclophosphamide, or even CNIs. Okay. Now, coming to the revision of treatment, whatever we have discussed till now, if patient has mild proteinuria, that is proteinuria less than 4 gram per day and GFR is normal, so this becomes the low risk category. Okay, so if this is the situation, we have to keep the BP target of less than 125/75. We have to give AC inhibitor and ARB to prevent proteinuria, diuretics to reduce the edema, anticoagulation if required, and also statins. Okay. Now, in the moderate or the medium risk group, that is proteinuria is between 4 to 8 gram and GFR can be normal or near or slightly deranged. Okay. In them, 6 months we can try alternative therapy like giving AC inhibitor, ARB, diuretic, and statins. But after 6 months, if you find that the patient is having persistent proteinuria more than 4 gram per day, then it is an indicator that this is not working, and go ahead and start immunosuppression. It can be cytotoxic and steroid alkylating agent combination, which was called as Ponticelli or modified Ponticelli regimen. Then if that also doesn't work, then patient can receive rituximab or ACTH. Okay. If the patient has heavy urinary protein, that is proteinuria more than 4 gram or less than 8 gram and GFR is reduced, then we can try the antiproteinuric therapy for 3 months. If this doesn't work and urinary protein is persistent to be more than 8 gram, then patient should go ahead and directly receive therapy. The difference between the medium risk and the high risk group, that is more than 8 gram, is that we wait only for 3 months for the antiproteinuric therapy to work. If that is not working, we go ahead and start immunosuppression. Once immunosuppression starts, it is easy. It is simple. So you have to decide whether you will choose modified Ponticelli, you will choose rituximab or CNI. And then if that doesn't work, secondary therapy you will give rituximab. Okay. Now, KDIGO has released guidelines for the management of membranous nephropathy in adults and in children. Okay. So what does KDIGO 2012 guidelines say? First thing that is important is we have to do appropriate investigation to rule out secondary, like for lung carcinoma or for colon carcinoma, any appropriate investigation has to be done. Then initial therapy, for whom will we give immunosuppression? If urinary protein excretion persistently exceeds 4 gram per day and it remains over 50% of the baseline value and it does not show progressive decline with all the therapy for 6 months. So if you go back, this is the group they are talking about where proteinuria is more than 4, less than 8. But after giving 6 months of treatment with AC inhibitors and statins and other antihypertensive, proteinuria has not reduced even to 50% of the baseline, or proteinuria is persistently above 4 gram. Okay. Second thing is, if the patient has severe, disabling or life-threatening symptoms related to nephrotic syndrome. This I told you, most commonly it means thrombosis. It can be venous thrombosis, rarely arterial thrombosis. So if this is occurring, then we have to directly go ahead and start immunosuppression. Again, if serum creatinine is risen by 30% within 6 to 12 months from the time of diagnosis, but it is not less than 25 to 30. See, because if GFR is less than 25 to 30 already when patient comes for review, then there is no point in putting immunosuppression, because immunosuppression is going to damage the kidney more, right? So if serum creatinine has increased by 30%, like last year it was 1, this year it's 1.3, then also we should consider adding immunosuppression for these patients. Now, if creatinine is more than 3.5 or if GFR is less than 30, do not start the patient on immunosuppression. Till now we learnt in whom we should give. Now we are learning in whom we should not give. Okay. Prophylactic anticoagulation has to be given when albumin is less than 2.5. Okay. Otherwise, this is done to prevent the hypercoagulability. Now coming to remission. What is the definition of remission? This is adapted from 2012 KDIGO guidelines. it is classified into two. One is complete remission, other one is partial remission. Okay. Now, complete remission is if urinary protein excretion is less than 0.3 gram per day or 300 milligram per day. Okay. This has to be confirmed by doing two values at least 1 week apart. That is, today you do, if today is Monday, then again you do next Monday. Okay. And a normal serum creatinine. So, the serum creatinine should be normal and proteinuria should be less than 300 milligram per day. This is complete remission. Partial remission is when proteinuria is less than 3.5 gram per day and you see that there is more than 50% reduction from the peak value. Okay, it might not reach the normal range of 150 or 300, but it is less than 3.5 gram and 50% reduction from the time of starting treatment is noticed. Okay, this also should be taken two values 1 week apart, and then we have to also see that stable serum creatinine is there and normalization of serum albumin. Okay, so serum albumin normalizing meaning proteinuria has reduced. Okay, so all these are the factors that we have to include while defining complete remission and partial remission in membranous nephropathy. Now, coming to the Ponticelli regimen and the modified Ponticelli regimen, if we are deciding to give immunosuppression, this is the best treatment available. So, in the Ponticelli regimen, it was said that IV methylprednisolone has to be given 1 gram, which is followed by oral methylprednisolone 0.5 milligram per kg per day. So, this is Ponticelli. So, what did modified Ponticelli say is the oral methylprednisolone had become oral prednisolone. Okay, same prednisolone, which is given for 0.5 mg per kg per day for 27 days. So, in a month, if this is 6 months treatment, in first month, second, third, 4, 5 and 6. So, month 1, month 3 and month 5, you give this, there are 30 days, right? 1, 2, 3, 4 and here I'll write 30. So, this 3 days you give pulse steroid, followed by these days you give oral steroid, right? And in 2, 4 and 6 months is when you are going to give alkylating agents. If it is Ponticelli, then chlorambucil or cyclophosphamide. There was an option to use chlorambucil or cyclophosphamide, but cyclophosphamide was more preferred. In modified Ponticelli, it is cyclophosphamide. So, these are the two important difference between Ponticelli and modified Ponticelli, that is oral prednisolone was used and cyclophosphamide was used. Okay, so here cyclophosphamide is used. It is generally given at the dose of 2 mg per kg. This is done for 30 days. So, this keeps alternating and it's 6 months treatment is completed. Now, what are the risks and benefits of giving Ponticelli regimen, which has an alkylating agent? Okay. Now, there is enhanced risk of opportunistic infection. There is reactivation of viral hepatitis, alopecia, gonadal damage like aspermatogenesis and ovulation failure. So, if you are starting this treatment for a young person, then it is better to suggest all these regimens. Okay. Then hemorrhagic cystitis with cyclophosphamide only. Neoplasms, if it is there, cyclophosphamide can worsen it. So, in neoplasms, try to avoid this. Then transitional cell carcinoma of the bladder, ureter and pelvis and toxic hepatitis. So, all these are the risks. Benefit is it is going to prevent CKD, ESRD, complications of nephrotic syndrome, and hence it prolongs life and also quality of life. So, basically the progression to ESRD is prevented by giving this regimen. Now, what are the contraindications for Ponticelli? So, first is untreated infection, maybe HIV or hepatitis. Any untreated infection is contraindicated. Next is neoplasia because it has malignant potential. So, lung, skin, breast, colon, anywhere. If there is urinary retention and there is inability to comply with monitoring. That is, we have to call the patient to monitor WBC count, which can get suppressed. So if this is not happening, then it is better not to start. Okay. If there is pre-existing leukopenia and if creatinine is more than 3.5. So these are the contraindications for starting Ponticelli regimen. Creatinine more than 3.5 means already the kidney has gone into CKD and giving immunosuppression might not help. Now, that is about Ponticelli and modified Ponticelli. Now, what are the CNI based regimens? Okay. Now, coming to cyclosporin. Cyclosporin is given at the dosage of 3.5 to 5 mg per kg per day, which is given orally in 2 equally divided doses 12 hours apart. That is, generally it will be given at 8 am and 8 pm. This has to be given along with low dose steroid, that is 0.15 mg per kg per day for 6 months. And they are suggesting to start at lower range of CNI and gradually increase if there is no nephrotoxicity. Tacrolimus is started at the dose of 0.05 to 0.075 mg per kg per day. Okay, and it is given orally in 2 divided doses, same 12 hours apart. And this, once given with tacrolimus, it is given without steroid. Okay, with cyclosporin, when you are giving, it is important to give with steroid. Tacrolimus, that is sufficient to give without steroid, and additional steroid can much worsen the risk of diabetes. So it is generally given without steroid. Okay, and it is generally suggested to start at a low range and then increase gradually to avoid nephrotoxicity. Now, that was about KDIGO 2012. Now, KDIGO glomerulonephritis guidelines are not revised since 2012. So, in 2020, a public draft guideline was released, as in it was approximately a 400 to 500 pages booklet that was released, and it was kept for public opinion to make any necessary changes. The final guideline is not yet out, but then this guideline gave so many, this public draft, which is just a sample guideline, gave so many important points. So here I have picked it up and I have used it here. As of now, this public draft guideline is being removed from the KDIGO website. It is not available in the website, but I have removed this section and I am using this because it gives a nice outlook and it also incorporates the recent therapy with rituximab, because from 2012, after 2012, a lot of trials have come which supports use of rituximab primarily. Okay, so I discussed there are 3 regimens, right? First is the modified Ponticelli. Second one is CNI based regimen, that is cyclosporin plus steroid. Third one is rituximab. So generally, any patient comes in the olden days, modified Ponticelli would be the first treatment regimen that is initiated. But then after finding out, there are trials which I will be dealing with in the section of trials, which prove that rituximab is equally good. It is doing as good as modified Ponticelli. Then it was challenged, the notion of using only modified Ponticelli was challenged. So think, what are the problems modified Ponticelli can cause? We are giving cyclophosphamide, right? So it can affect the fertility of the patient and it can cause malignancy risk. So if a patient is coming, it is a young lady or a young male, instead of affecting the fertility by giving cyclophosphamide, we can try rituximab in those patients. Similarly, another group of patients for whom rituximab will work is if they have failed other immunosuppressive therapy. Okay, so rituximab currently is being used very much as first line therapy, as good as modified Ponticelli. Generally, CNI is not used as first line therapy in some condition where both these things cannot be used, like patient has some infection or severe immunosuppression already, when these 2 regimens cannot be used, that is Ritux or modified Ponticelli cannot be used. In that situation, we go ahead and use CNI with steroid. Okay, so let us see what this public draft guideline says. So they tell, when the patient of membranous nephropathy comes, we have to screen for secondaries, that is chest X-ray to rule out sarcoidosis, history of drug use like NSAID, gold, penicillamine, presence of anti-nuclear antibody to diagnose SLE, full history of any systemic diseases, thyroid diseases, and physical examination of skin or joints to see for autoimmune disease. HBV, HCV, HIV, and treponema, all these are infections that can cause membranous nephropathy. Ultrasound of the kidneys and screening for malignancy, age appropriate screening for lung carcinoma or GI carcinoma has to be made. Now, they classified again the population into 4 risk. Okay, first is low risk, that is remember mostly it is based on 1, 2 or 3 criteria, that is what is the GFR of the patient, how severe is the proteinuria. Some people use albumin also. So if the patient has GFR, proteinuria and albumin, right? So if the patient has normal GFR, proteinuria less than 3.5 and serum albumin more than 3, then this is considered as low risk group. Moderate risk group, okay, that means normal GFR, proteinuria which is more than 4 gram per day, or there is no reduction less than 50% for 6 months of giving the therapy, okay. And in this group, additionally, we have to see PLA2R receptor antibody level, okay. If PLA2R receptor antibody level is less than 50 and the proteinuria is generally mild low molecular weight where selectivity index is low, okay, and urinary IgG is less than 250. That means there is no severe tubular damage, there is no tubular proteinuria, okay. So all this will indicate that they are in moderate risk group. Now high risk group becomes if GFR is less than 60, proteinuria is more than 8 gram per day for 6 months, right? And here PLA2R receptor antibody in the high risk group is more than 150. Here in the moderate or the medium risk group it was less than 50. In the high risk group it is more than 150 and urinary IgG is high, selectivity index is also high, okay. Now coming to very high risk group, this is where there is life threatening nephrotic syndrome, rapid deterioration of kidney function that is not otherwise explained, and high low molecular weight proteinuria in 2 urine samples collected with intervals of 6 to 12 months. So the IgG levels or low molecular weight proteinuria is very, very high. So very high risk is when there is severe complications of nephrotic syndrome. Other than that, based on these parameters, it is divided into low, medium and high risk, okay. So apart from what we discussed previously, here you can see that the levels of PLA2R antibody is important in classifying these patients, okay. Now, as patient comes, first we do risk evaluation, okay, that is what we saw previously. So if it is low risk group, we wait and watch. If it is moderate risk group, we can give rituximab or CNI, that is it is not a severe disease. If it is in this moderate risk group, we can give rituximab or CNI, okay. Now if it is high risk group, another addition, that is modified Ponticelli, also gets added because it's a very, very powerful medication regimen. Generally it is used only for high risk group, okay. And very high risk, that is the last group, can use cyclophosphamide alone because they require intense immunosuppression. Now once we start, how do we monitor? So at 0 months you start either rituximab, CNI plus steroid or cyclophosphamide along with steroid, that is Ponticelli. Then at 3 months you are going to remeasure the PLA2R receptor antibody, okay. Now if the PLA2 receptor antibody, there are 3 possibilities. There is, it is absent, it has not changed, or it has increased, okay. There is absent, that is it has decreased, or it is static, or it is increased. Now if it is absent, then there is no requirement of any additional therapy. So if you are given rituximab, don't give any additional dose. If you have given cyclophosphamide, you can taper the dose of cyclophosphamide. If it is CNI, you just continue the therapy. Now PLA2 receptor is static. Then if you are given rituximab, you give extra doses, you continue cyclophosphamide and continue CNI inhibitor. Now if it is increased, that means you have to become very active. If you are given rituximab, give the patient extra doses of cyclophosphamide, okay. If you have given cyclophosphamide, it is showing that the cyclophosphamide is not working, so give rituximab to the patient, okay. And if you are giving CNI inhibitor, you can add either cyclophosphamide or rituximab. So this is the decision you make at 3 months. Then again you do the PLA2R receptor antibody at 6 months, okay. Now here also 3 possibilities. One is it is absent or low. That is then what you will do? Again same. You don't give any additional doses of rituximab. Cyclophosphamide you will taper, and you will consider stopping as per the treatment regimen, and CNI you will continue. Okay. If it is same level or moderately increased, then you give additional therapy like previously discussed, again with standard agents. If it is high titers or persistently increasing, we have to treat it as resistant disease. I'll come to the treatment of resistant disease. Now, how do we manage relapse? Okay, so first initial treatment is rituximab. If the patient has responded to rituximab in the relapse, you repeat rituximab. If we give CNI inhibitor, relapse, first line drug becomes rituximab with or without CNI inhibitor. Okay. Third is if the patient is on cyclophosphamide and patient relapses, then you have to give patient another dose of modified Ponticelli can be given, which is maximum. If the patient previously has received 2, then it is better to go for rituximab. Now, what is treatment resistance? So, initial treatment, if it is with rituximab, then you see if the EGFR is stable, if the EGFR is decreasing. If the EGFR is stable and the patient is having resistant disease, can add CNI plus rituximab. If the EGFR is declining, then we do not have time and we cannot give CNI inhibitor, so we prefer cyclophosphamide. Even after that there is no response, cyclophosphamide. See, basically any disease that is resistant to one or the other drug, cyclophosphamide is given. Okay. So, first group is when you are giving rituximab, if the EGFR is declining, you consider giving cyclophosphamide. This table might be confusing, but I'll just simplify it for you. If patient is resistant with rituximab, you give the patient cyclophosphamide. Okay. Second group, where we have given CNIs. Here there are two possibilities, that is EGFR is stable. In that situation, we have to give rituximab. Okay. If it is CNI, first is you give rituximab. Okay. Then if the GFR again is, if the kidney again is showing continuation signs of relapse, then you give cyclophosphamide. If the EGFR is declining, do not wait for this step, skip the step and directly go and give cyclophosphamide. Okay. Now, cyclophosphamide patient, if the EGFR is stable and patient has relapsed, try rituximab. Repeat cyclophosphamide can be tried. If EGFR is decreasing, try cyclophosphamide. So, it is important to know that when there is a resistant disease, cyclophosphamide is what is used most commonly, whether it is in the Ritux group or cyclo group or cyclosporin group or the cyclophosphamide group. Now, about recurrence of this disease post transplantation. Okay, if it is a known PLA2R receptor antibody associated MN, then you measure the PLA2 receptor antibody. If it is positive, then there is high risk of recurrence. If it is negative, that means the antibodies are disappeared, the risk of recurrence is less than 10%. Okay, and if it is negative, if the serum is negative, we can do biopsy of the native kidney and stain it for PLA2R antigen. So, if just PLA2R antigen is present and the antibody is absent, that means there is medium risk of recurrence, which is around 30%. Okay, even if the PLA2R antigen status is antibody status is unknown, then we have to follow this. Probably we'll do a biopsy and we'll stain the PLA2R in the kidney and see. Now, the recurrence rate depends on the evaluation of the causative antibodies. It may be higher after living related donor transplantation, but the benefits of the living donation outweighs any harm caused by recurrence. Okay. In the peri and post transplant period, every month monitor for proteinuria. Okay. And in patients with known PLA2R receptor antibody associated membranous nephropathy, measure this antibody every 1 to 3 months depending on the pre-transplant status. If it is increasing, then there is increased likelihood of recurrence, consider biopsy. If it is decreasing, low likelihood of recurrence, and only if indicated, kidney biopsy has to be performed. Now, treatment of recurrence. How do we treat? If at all recurrence occurs also, how do we treat this condition? Okay, we have to treat with AC inhibitor or ARB initially. Immunosuppressive therapy has to be monitored or optimized. See, generally the treatment for that is immunosuppression. Here patient is already receiving. So we have to optimize it. If it is less than 1 gram per day on all these things, then you see the patient at 1 to 3 months interval. If proteinuria is more than 1 gram per day despite all your efforts, then it is time to add another immunosuppression, which is rituximab. Rituximab 1 gram per day is given at day 1 and day 15. Okay. Now, coming to what is the anticoagulant therapy that is used in membranous nephropathy. So, if serum albumin is less than 2 with the bromocresol purple technique, or less than 2.5 with bromocresol green technique. Okay. Now, if it is less than 2.5, then there is high risk of venous thromboembolic events. Assess the bleeding risk. If the bleeding risk for the patient is high, then give aspirin. If bleeding risk is low, then give warfarin with low molecular weight heparin. Okay. Now, if the serum albumin is more than 2.5, you see whether if serum albumin is more than 2.5 or less than 3.2. Okay. If it is more than 3.2, then there is no need for aspirin. If it is less than 3.2, again you see the risk of arterial thromboembolic event. Okay. That is, if there is high risk of arterial thromboembolic event, then you treat the patient with aspirin, and if there is low risk, there is no need for aspirin. So basically you have to assess the bleeding risk, the thrombotic risk, when albumin falls less than 2.5, and then you have to start the treatment. We know that nephrotic syndrome, there is hypoalbuminemia because there is loss of albumin in the urine. Okay. So, the degree of hypoalbuminemia predicts what hypercoagulability is seen, because when the albumin is lost in urine, liver wants to synthesize more protein. So, it synthesizes all proteins, which involves coagulation factors. Okay. Plus, there are few anti-thrombotic agents which are lost in the urine. So, these two things coming together increases the clotting risk in patients. Okay. Now, coming to the last part of this chapter, let us go into the high yield questions. First is, where is megalin seen? We know that megalin is seen in Hayman nephritis. It is a rat model of membranous nephropathy. The types of mutations seen in primary membranous. There are 4 important mutations, which is anti-PLA2R receptor antibody, anti-thrombospondin antibody, third is anti-NEL1 antibody, 4 is anti-SEMA3B. Okay, so these are the 4 antibodies that are seen in primary. Spike-like configuration in GBM is seen in stage 2 of membranous nephropathy. Difference between primary and secondary. In primary and secondary, the difference is, in primary it is mostly IgG4 that is seen, and here in secondary it is IgG1. IgA and M are absent in primary, it is present in the secondary thing. Okay. Complement seen C1q is not seen in primary, C1q is seen in secondary, especially in lupus. And the deposition of antibodies, it is mostly subepithelial deposits in primary. Here it can be mesangial or subendothelial. Okay. So this is the difference between primary and secondary. Hepatitis B associated MN, it is mostly seen in the endemic area in small children, and it is mostly going into spontaneous remission. Malignancy associated MN, it is one of the most common cause of MN in adults more than 50 years, and the malignancy causing membranous nephropathy are solid tumors involving the stomach, lung, prostate and colon. So, significance of anti-PLA2R receptor antibody is that the anti-PLA2R receptor antibody is useful for diagnosis, the initiation of immunosuppressive therapy, the monitoring of therapy, and also deciding when to stop immunosuppression. Okay. Ponticelli and modified Ponticelli, it is nothing but alternating steroid with alkylating agents. The steroid that is used in Ponticelli is methylprednisolone 3 doses followed by methylprednisolone oral for 27 days. In modified Ponticelli, it is mostly prednisolone. And again, in Ponticelli, it can be chlorambucil or cyclophosphamide. In modified Ponticelli, it is cyclophosphamide. Okay. Role of rituximab is that It can be used in patients in whom Ponticelli regimen is tried 2 times, where cyclophosphamide cannot be given again, and also in young patients in whom fertility has to be preserved, and also in patients who have failed immunosuppressive therapy previously. So, these are the indications or role of rituximab in membranous nephropathy. So, this completes this session. Thank you, friends.